Hi, I'm giving this talk as part of the Café Scientifique program, and this is actually part of the British Science Week series of events. So the title of my talk is Psychotherapy Without a Therapist, a 21st Century Solution to Common Mental Health Problems. And in this talk, I'm going to be kind of partitioning it into three different parts. The first part is the problem. I'm going to talk about the problem and hopefully expand and explore that a little bit. The second part is I'm going to offer some and then explode some myths that I think in part keep the problem in place and prevent adequate solutions to the problem. And in the third part, I'm going to offer some solutions to the problem of common mental health problems. Now, mental health problems are incredibly common, and of course there are lots of them, things like anxiety, depression, generalized anxiety disorder, phobia, panic, etc. But I'm going to be talking mainly about depression, and I shall also add anxiety on from time to time. The problem I'm speaking about is depression. Now, depression is a devastating, underdiagnosed, and undertreated disease. Depression affects not only the individual, for which it is devastating, difficult, and horrible, really. It also affects the family. It affects the community, it affects society, the economy. It affects everything. So, depression is a really, really big problem, and yet it's not that hard to cure if you know how. Depression is not that hard to treat, not that hard to cure if you know how. So why then are there 19,500 depressed and anxious people in Reading tonight? Reading's the location that I'm in, and the locality of Reading, which is a kind of a conurbation, is about 200,000 people. So there are 19,500 depressed and anxious people, not just a bit down or just a bit fearful, but clinically depressed and clinically anxious people. The local football stadium, called the Majeski Stadium, holds 24,161. That's almost the whole of the stadium. If you added in panic disorder, you'd pretty much get to the 24,000 needed to fill the stadium. So, it's a big problem. It's not that hard to cure, not that hard to treat, and yet there are still enough people who are depressed and anxious in the Reading locality tonight to fill the football stadium. And it's not even news. I mean, it wouldn't be true to say that no one cares, but it's a bit like no one cares. It's not even, anything which you can make the paper with, not even the free paper. People just don't seem to care about it. It's almost as if there's a kind of a collective block to seeing this problem. Women suffer depression and anxiety at levels almost twice those of men. And depression itself is increasing. The World Health Organization reckon that depression is the fourth largest burden of disease in the entire world, greater than AIDS. But depression by 2020 will be the second largest burden of disease. It'll pretty much only have the larger burden of disease will be a cardiac problem. So depression and anxiety are increasing. They're not that hard to cure, and yet we still have 9.2% of the British population, about 1,250,000 depressed people in Britain. Now, it's not that there are depressed and anxious people and then there are the rest of us. Everybody will know someone who is depressed or anxious. Many times that'll be someone that's in their family. About 1 in 6 of us will experience a common mental health problem like depression, stress, one of the anxiety disorders at some point in our lives. So the reason we should care about this is that because it will affect us or our family at some point. Now I'd like to just offer some facts about depression and depression treatment. GPs are our first port of call when we have any kind of problem. That's absolutely fine. If you've got a problem, you go to your GP. GPs spend about 20% of their time with common mental health problems, which is a shame really because they're not very well set up to deal with them. So what they do is they prescribe antidepressants or some other kind of treatment. 93% of GPs give antidepressants because there isn't an alternative. In Britain, there are approximately 31 million prescriptions for antidepressants given out every year, which is a half a prescription for every person in the country. And worldwide, Prozac is the most popular antidepressant. 54 million users. Now, the population of UK is about 60 million, So it's almost as if every single person in the United Kingdom is a Prozac user. That's a vast, vast number of people. Now, depression affects every aspect of someone's life. Generally, we spend about a third of our time at work, which is interesting because about a third, 33% of all absence from work is related to depression. Depression costs the economy about 8 billion. And of course, if you think about it, people who are at work are not performing necessarily as well as they're able. That's called presenteeism. Secondly, there's the cost of time off. People who are depressed or anxious have more time off work. There's the cost of benefits. There's the cost of treatment. All in all, £8 billion. I'll tell you why that becomes important later on in the talk. And we mustn't forget, of course, that depression reduces life expectancy to some extent, and it certainly has a mortality cost associated with it, which in the UK is about £500 million, just over £500 million. So, depression is a serious, really serious, worldwide problem. It's not that hard to treat, not that hard to cure. Why then do we still have the problem? Well, let's go to the doctor, because that's your first port of call. What will your doctor do for you? Overwhelmingly, your doctor will give you an antidepressant if you present to him or her as depressed or even anxious. They'll still get an antidepressant by and large. Historically, if you're lucky, you might get some counselling. So why is that? Why is it that you will get an antidepressant? Well, let's ask the question, are medical treatments that useful? Well, I'm going to say not really. I want to say an antidepressant is not a very useful treatment. However, if you've got a broken leg, then you definitely should go to your doctor. A cardiac problem? Yes. Diabetes? Yes. Bacterial infection? Definitely. I'm a great fan of antibiotics. Depression? No, not really. Anxiety? No, not really. So how is it that we have acquired the understanding that doctors are the person to go to when you have a common mental health problem? Well, we've got to kind of take a step back and look at how successful medicine has been. Well, medicine's a technology, really, for applying science, or the discoveries made in science. There are some significant discoveries that have changed the quality of our lives. We are healthier, we're better able to enjoy the things we do, and we suffer much, much less pain and discomfort than previously because of a number of important discoveries. I made a little list. On my list, I put antibiotics, anesthetic, x-rays, the contraceptive pill, the ability to do surgeries, particularly open heart surgery, the discovery of the circulation of the blood, the discovery of insulin, and the development of chlorpromazine, which was the first antipsychotic, the discovery of germs and how they multiply and move around, DNA, bacteria, all that kind of stuff. So science has been incredibly useful or important in developing things which affect our life. Medicine has been very important in applying these to our everyday experience. So medicine is actually a very successful enterprise, and if we've got a problem, then we're right to go to our doctor, except that we have mistakenly assumed that our doctor knows what to do about common mental health problems like depression and anxiety. The problem is depression and anxiety are not medical problems. They're psychological problems, and therefore a medical solution does not work that well. And that's the problem. And a doctor doesn't really have an alternative. It doesn't really have anything else that they can give you. Now, let's look at myth number one. We've explored the problem a little bit. Let's look at some myths. The first myth is that antidepressants are useful. Well, antidepressants are not that useful. 60% of people who start antidepressant will be off them in 3 weeks because the side effects are unpleasant and they don't want to take them. Between 68 and 85% of any clinical effect that you get from an antidepressant is a placebo effect. Now, a placebo is not nothing. A placebo is the psychological effect of belief, expectancy, and desire. You want something to be helpful to you, and therefore it becomes helpful because of the psychology of it. So virtually all of the clinical effectiveness of antidepressants is due to placebo. I mean, that's even recognized by the government in the UK now. Not even antidepressants are not even recommended for mild up to moderate depression, and even with severe depression, it's still considered that they might be useful. They're worth trying. Antidepressants are not a useful treatment strategy, and yet I mentioned earlier, there are 54 billion users just of Prozac, and Prozac's not the only antidepressant, it's just the most popular. There's a big myth out there that keeps people using antidepressants. Right, well, this is my point. An antidepressant is not necessarily the right treatment. You might get some psychological benefits from taking it, but it's a placebo effect, mainly. Now, I'm not suggesting that the whole thing's a con, but it certainly looks a bit like that. Information which doesn't support the use of antidepressants tends to be suppressed. It doesn't get published. In general, null results or results where there are no findings tend not to get published. The whole thing needs to be revised. Okay, the second myth. Complex problems require complex solutions. Well, they don't. Way back when, in the 1880s, 1890s, when Freud was formulating his original psychoanalytic theory, he started to see the development of problems as quite complicated things, human problems, psychological problems, quite a complicated process. And he therefore developed a relatively complicated embryonic treatment strategy. Although Freud himself wasn't averse to a bit of brief therapy, he cured Gustav Mahler of paralysis in his arm in one 6-hour session. So he was a little bit more flexible, but his followers became more and more wedded to the complexity of his origin myth. And they then created very complicated solutions. So they end up with a stereotype of, on the therapist's couch for 3 times a week for 5 years, and for the first 2 years the therapist doesn't speak to you. If that was the treatment that was on offer in the 30s, 40s, 50s, 60s, even 70s, it's no wonder that primary care, GP-level treatment for mental health problems doesn't really exist, because that's far too much time, money, and effort to treat something. So the idea that complicated problems require complicated solutions has meant that common mental health problems such as depression and anxiety have not gained a treatment strategy other than the antidepressant, which, as I've said, isn't much of a treatment at all. The third myth I would like to explore is that therapy needs a therapist. Psychotherapy needs a therapist. Well, it doesn't. As with much science, the theory that you bring to the enterprise determines what you will see. So the world view that you have focuses your mind so that you will find things which are relatively congruent with that world view. Now, I've demonstrated quite satisfactorily that therapy without a therapist is very doable. Therapy does not need a therapist. In our Blues Begone trials, which I'll be talking about a little bit later on, we have treated hundreds and hundreds of people, and they get clinical outcomes which are on par, even better in some cases, than face-to-face psychotherapy without a therapist in the area, without a therapist in sight, without ever seeing a therapist. How do we do that? Well, let me talk about cognitive behavior therapy now then. CBT, or cognitive behavior therapy, provides a treatment model based in psychology. Now, with psychotherapy, we talked a little bit about Freud. He had a complicated notion of how problems are created and a complicated notion of how problems are resolved. Well, CBT gives a good indication, it gives a good map of how problems are created, but it's relatively simple. Simple to understand, simple to discern, simple to kind of share. But it also gives a good map of how to create a solution and what a solution looks like. It's simple to understand what you need to do to resolve a particular problem. It's simple to see the effects of it. So generally, CBT is a relatively brief treatment, but it's very effective. It's more effective than all these other things that are complicated. But fundamentally, CBT is a technology. It's a way of doing things that deliver good clinical outcomes. Now, you may not know much about CBT, and there's no reason why you should in particular. But let me just talk a little bit then about the kinds of things that would be in virtually every CBT treatment, no matter what the problem. But the first one is cognitive reappraisal. We always want to challenge cognitions or thoughts for their validity. Now, if someone's depressed, it is guaranteed that they're underestimating their strengths and resources, and they're overestimating their perceived failings. So we would need to restructure and recalibrate, if you like, those beliefs, ideas, to more effectively reflect reality. And we can go down in levels in doing that. The first level is what I call ants, automatic negative thoughts. We need to challenge automatic negative thoughts. These are those self-destructive or self-critical thoughts that just pop into your head. I'm no good as a public speaker. We need to stamp on ants. But then it goes a bit deeper. I'll never be any good as a psychologist would be my example. That's a core belief. That's something that's a little bit deeper. It's about me as a person. We need to challenge that. It's not true. Or I've challenged my core belief. It's not true. It's not true that I'll never be any good as a psychologist. But unless they're challenged, those kind of negative ants and core beliefs, they destroy good mood. They destroy the sense of security. The second thing we always need to do is to reduce avoidance. If I thought that I was no good as a public speaker, I would avoid public speaking engagements. Obviously, it makes perfect sense. But if it's not true that I'm no good, and that I'm avoiding something which would help me to realize that that's not true, avoidance is a very human and a very normal way to try to cope with something that's unpleasant. But when it starts to become something which is really quite important, avoidance is usually a mistake. You can get away with a lot of avoidance. But where depression and anxiety are concerned, it's a mistake. The third thing is that we need to reduce the meaning of psychological symptoms. Very often people who are depressed or anxious also have physical problems that trouble them. Things like pain, problems with sleep, problems with eating, problems with exercise of one sort or another. And they can interpret these physical characteristics as meaning something quite fundamental, such as I'm not well, I'm ill, I'm not going to get better. And that then also creates a lot of negative emotions. A good example would be if you were socially anxious and you found yourself in a crowd of people. You would want to run away. Running away, of course, confirms to you that you are right to be anxious because running away makes you feel better. However, that is the wrong thing to do because it's responding to the emotions created by the negative cognitions. Hope that's not too complicated. If you run away, okay. The next time you're in a smaller group, you run away, you feel better. The next time you're in a group of 3 or 4, you run away, you feel better. The next time you're in a group of 1, you run away, you feel better. Next thing you know, you're stuck in your bedroom. We've always got to challenge the negative emotions when they occur in the event itself. All of that is relatively straightforward to do. It's quite well worked out. It's not rocket science in a sense. It still requires a whole lot of therapists to do it because you still have to have face-to-face therapy. So this brings me to my next point. And I firmly believe this. All psychotherapy is self-help. The therapist points the way, but the client does the work and makes the change. I mean, in therapy, you don't touch the client, you don't give them a pill, you don't poke them. You talk. That's pretty much what you do. You talk, you go through some exercises. The client has to make the change. The client has to take on board that cognitions need to be challenged. We'll talk a little bit about how we've developed a way of doing that. People have the capacity for initiative and creativity and productive thinking. They can integrate information and understand stuff. And furthermore, a lot of people, not everyone, a lot of people want to understand the why and the how of the problems that they struggle with. And that's absolutely fine. So, if we want to create a treatment that can treat 19,500 people or 1,250,000 people now, right now, today, we need to use the CBT model. We also need to simplify it in some way. See, most people don't get any help at all. To treat large numbers of people, it's going to take something a bit different. So we've extracted the CBT treatment model out of the CBT kind of literature, if you like, and we've taken the therapist out of the picture. Now, you might say, well, why not read a self-help book? Is that not the same thing? Lots of self-help books about CBT. Problem is that self-help books are not engaging. They tell you about the problem, but they don't hook you into it. They're not sticky enough to keep you engaged. Now, some are more helpful than others, and in research trials, you can kind of keep a person using the thing because it's in a trial and they feel an obligation, and they may get some benefit from that. And in those circumstances, often self-help books are shown to be helpful. Not everyone who gets a self-help book is in a trial, so we need to create a more engaging strategy. And that brings us to our solution to this problem. We created a program called Blues Begone. We started 10 years ago. Oh my word. It's most of my career. Blues Begone is the only home-based system that really treats and cures depression and anxiety. And I'm so confident about that I guarantee it these days. If you use Blues Begone, it will help you. Anyway, you get Blues Begone on a USB stick, or you can download it, and you install it on your computer. The first thing that Blues Begone does is it assesses you, and then it creates a roadmap to your recovery. Now, the roadmap is your unique treatment map. No two roadmaps will ever be the same. No two people will ever see the same Blues Begone, so it's unique and personalized. I think that's really an important characteristic of it. The roadmap will give you about up to 40 hours of CBT. Now, 40 hours of CBT is a lot of engagement with resolution, the resolution of the problem. There's lots of talking heads and cartoons and animations and tasks to do. Pretty much we would say to somebody, do a bit every day or 5 days a week and have the weekend off. But basically do a bit often. It takes about 8 to 12 weeks to work through the whole program. But anybody who works through the whole program is pretty much going to get big life changes. And therefore it is worthwhile. What's the secret in a sense? How did we take CBT with a therapist and turn it into something that people could do themselves using the Blues Begone program? Well, we created a treatment strategy, a model, a way of doing things called active self-help. And the best way to understand active self-help is to understand the 3 N's of active self-help. The first N is the client needs to understand what the problem is. Now, you might say, well, I'm depressed. That's not the problem. That's the consequence of the problem. The problem probably is that you underestimate yourself. You overestimate your faults and failings. You might say, well, my problem is I'm anxious. No, that's not the problem. The problem is you're fearful, and anxiety is the manifestation of that fearfulness. The question then becomes, are you right to be fearful? Is there something that you need to be fearful of, or is this an overestimation of threat? So we establish what the problem is to the client's satisfaction so that they understand what they're working on. You can't just kind of work on depression. Well, you can, but it's not easy. You can't just work on anxiety because there's nothing to get a hold of. So you need to understand what the problem is. The second N is you need to understand, you need to know what to do about it. Well, typically you get that from a therapist. You know, they'd say, well, you need to do this, you need to do that. But that doesn't have to be the case. Blues Begone tells you, shows you, illustrates to you what you need to do. The third N is you need to know how to do it. Well, again, a therapist would normally run you through that, but that doesn't have to be the case. Blues Begone tells you, shows you what you need to do, and it shows you how to do it. And then it supports you as you do it. It gives you lots of opportunities for applying the Blues Begone active self-help method. So when people use active self-help, 60% of people are cured of depression if they're clinically depressed beforehand, and about 50% are cured of anxiety if they're clinically anxious before they use the program. And in both cases, an additional 10% get big gains, but not quite enough to take them out of the definition of clinical anxiety. So if you start off at severely depressed and you finish up just above mildly depressed cutoff, you've made huge gains, but we wouldn't then consider you to be cured. That is as good as any therapy gives, and it's better than antidepressants by far and away. So I've said then there are 3 kinds of treatments, basically. There are antidepressants, therapy, and active self-help. With antidepressants, you go to the doctor, you get the antidepressant, you take it. You learn nothing about your problem and how to resolve it, and you keep nothing. Therefore, 60% of people who use antidepressants will relapse within 2 years. With CBT, with therapy, you may learn something, if you have a good therapist, and you may keep something, and therefore the relapse rate is much lower. With active self-help, you learn everything because you have to do it yourself, and you keep everything. So in our follow-up studies, the relapse rate is very, very low. We just followed up 20-month follow-up of a group who used Blues Begone as part of a clinical trial, and there's no relapse at all. Now, we didn't get to follow up everybody because not everybody wants to be followed up, and people move away and we lose addresses, but the people that we were able to follow up, the depression gains were maintained. Wherever you finished, that's where you were. So that you kept what you had achieved, and with anxiety, you continue to improve, significantly improve. So anxiety continued to go down. So that is very gratifying, and it really justifies the idea that if you do it yourself, you get to keep it. Now, in fairness, I said earlier on, it seems like no one cares. That's not strictly true. a well-known economist called Lord Richard Layard, said to the government, well, look, depression costs $8 billion a year. If we could get people back to work, stop them from having to have benefits, they get back into the tax system, they start paying taxes, it would pay for the treatment. So he reckoned the treatment cost about £750 per person. And of course, the traditional way of applying CBT or delivering CBT is to have a CBT therapist. So he said, let's have 10,000 more CBT therapists, and then we can treat people, and that will pay for the service. So the government put in £306 million, and they're busy trying to train 10,000 new therapists. In fact, I've been involved in some of the training myself. And it's not a bad idea, but no matter how many therapists you've got, I think here in Reading we probably have about 20 more therapists, you're not going to cure, not going to adequately treat the 19,500 people who are depressed and anxious tonight. So the problem with the strategy is this. It's highly labor intensive, very expensive, and it's 20th century thinking. No matter how many therapists you've got, you're not going to treat the 1,250,000 depressed people in Britain tonight. It's just a fact. There just aren't enough therapists. If you had 10,000 therapists, I don't know, what's my arithmetic? Each therapist has to have 1,000 clients. No, 1,250 clients. Is that going to work? I mean, a therapist can't have 1,250 clients. The only way that we're going to resolve these epidemic-like and increasing levels of depression and anxiety is to have a treatment strategy where people can access it when and where they want it at home without the on-costs, without the costs of having clinics and all sorts of other stuff. They can do it and they can get to keep the gains. If we delivered Blues Begone nationwide, we'd be able to cure 60% of people with depression and anxiety by July. Now, I'm giving this talk on the 15th of March, 2010. By July, we could have cured 500, 600,000 people of depression at a cost, in reality, it'd only be a couple of million. And they get to keep their gains. So, Blues Begone is one of the potential solutions. It's the only solution that really exists right now in terms of being able to do it, because it's the only really fundamentally useful home-based treatment. It doesn't require anybody else to interact with you to work. So, depression, well, it's a huge problem. It's not that hard to cure if you know how. Blues Begone cures depression and anxiety without a therapist. And if you use it, you get to keep the knowledge and gains that you make. It's the only kind of solution that's ever going to seriously treat depression and anxiety on the scale that we need to have it done. Thanks for attending and listening to this talk.